Yes, thank you very much, Michael. Dear colleagues, it's a pleasure to be here and to share with you a case which we treated a couple of weeks ago. These are my conflicts of interest. This is a video around 70 minutes long. We can stop this anytime, so please feel free to step up and ask questions. Then we can stop this in between. As just said, so this is my colleague, Michael Stocker. We have an echocardiographer, Michael Neubauer, as you will see, and Julia Federholzer, she was the anesthesiologist. Now, this concept of heterotópic tricuspid valve replacement has a history and has been developed early on and evaluated in animal models by Alexander Lauten and Hans Figula. And you see here a publication from 2018, already summarizing their first clinical experience. And the theory behind is that we're going to separate the back or the upper and lower extremities from the heart, so that there's no caval backflow into the upper and lower body halves. The Tric valve system is a pre-mounted valve system, which is here in this catheter tip. It's 27 French, has a soft tip here. And then very simply and easily, by turning this wheel, which is down here, we can unsheath the stent in the respective positions, in the upper caval vein and in the lower caval vein. Let's move a little bit further. There are currently 3 different sizes for the upper valve. You see here the 25, the 29, and the 33 millimeter device. The upper stent has like this little belly here, which we usually place in the confluence of the anonymous vein and the right subclavian or jugular vein. Then you see here that the lower part, the lower 50% more or less, is covered, so that we have here a nice sealing. And this is also here in the lower part where the actual valve is. Then we have 4 sizes for the lower caval vein, the inferior caval vein, which is coming here in a second, hopefully. Here it is. I'm going to stop this again. From 31 to 45 millimeters. Again, now in the upper part, as you can see it also in this picture up here, this part is sealed. The sealing is around 22 millimeter in height, depending on the different sizes. And this is also where the valve is located. And then we have the stent, which facilitates a good anchoring of the device in the correct position. Now we're going to present the patient now in the next few minutes here. This is a patient, as you will see in a second. He's 82 years old. He's symptomatic. He has New York Heart Class 3. The walking distance in the 6-minute walking test is significantly reduced, less than 100 meters. And as you will see in the echo assessment, he has a severe or torrential TR. He has a previous CABG surgery, left LAA resection in 2009, a cardiorenal but also cardiohepatic syndrome with a GFR below 30 and 35 and 40 milliliters per minute, elevated bilirubin, alkaline phosphatase, and gamma GT. Chronic atrial fibrillation, as most of those patients have, arterial hypertension, hypercholesterolemia. So we discussed, of course, this patient in the heart team. And due to these comorbidities, we thought that this patient, was jumping here, is too fast, is not a good candidate. We're calculating for a surgical procedure. The TRI score is a very recent surgical score, and it predicts the mortality. And in this patient, the predicted mortality was 22%. We did the right heart cath in this patient. The PA pressure was 50 in systole, a significant V wave in the right atrium of 46, so significant backflow. As you can see, in summary, it's a moderate post-capillary pulmonary hypertension. This is the medication which the patient was taking. Not very high dose of toracimate as the diuretic, but the combination of hydrochlorothiazides and toracimate, nothing. There was no possibility to increase this dosage, because then either he was hypovolemic and with low blood pressures, or the kidney function deteriorated even further. Now this is here the echo, the four-chamber view. This is the significant dilated right ventricle. You can appreciate the significant TR with the large coaptation gap already. The MR and TE is moderate, not severe. And then, as you can hopefully see in a second, also on the right side, there is the significant large jet over the entire commissure from the anteroseptal to the posteroseptal line of coaptation. This is the 3D, and I'm going to stop that here because this is also very important for our workup of how we're going to deal with these patients. You see here in this 3D view the septal leaflet, the anterior leaflet, and the posterior leaflet, and you can appreciate the large coaptation gap between the posteral and septal leaflets. For this workup, we have to understand that for other therapies, for an edge-to-edge therapy, for example, we would consider patients suitable for an edge-to-edge if the coaptation gap is probably below 8 millimeters, not above 8 millimeters. Here, we had a coaptation gap somewhere around 10 millimeters. And also the posteroseptal line of coaptation, if the origin is here, the hole is in its lower part, this is also less favorable for an edge-to-edge repair, and we see usually a higher recurrence rate for this patient. We also evaluated this patient as a next step for an orthotopic valve replacement within one of the ongoing studies, but due to this large annular size, this patient was also not deemed favorable for an orthotopic valve replacement. So the next option then is to consider this heterotópic valve replacement system, as you will see in the next few minutes. So let's see. Now we did the CT analysis. It's important to measure the caval vein size of the superior caval vein and the inferior caval vein. And with respect to these measurements, we get then the information of what kind of valve size. And in this case, a 29 millimeter for the upper one. And here's the lower assessment of the lower caval vein. And here a 35 millimeter caval vein was planned to have some oversizing with a good positioning of the valve. Now we're jumping into the procedure here. What you're going to see, this patient was not in intubation, but in analgesic sedation. We don't need to have a TE probe during the procedure. I prepared here both groins. On the left groin, you see an arterial access, but also a femoral access, in the femoral vein access for a pulmonary catheter. This is the white catheter in here. And on the right side, which we used then also for the tric valve placement, also a vein access. Now we're placing here the pulmonary artery catheter in the right pulmonary arteries, which serves us also as an anatomic landmark. And I'm doing injections here into the right jugular vein, and you see here the flow of the contrast in the superior caval vein, and you can also appreciate here the confluence of the anonomate vein. So because we don't want to obstruct that, so the vein with our stent. The fluoroscopy is very helpful for the placement of the first stent, as you will see in a second. So I'm placing here a Amplatz extra stiff wire into the right jugular vein. I prepared this access here. That's what I'm showing here is first with a pro glide so that we can close the access at the end of the procedure. But then in addition to that, I'm placing here a set suture which I can, and I leave this, the suture still in place, so I can use this by pulling it tight, that we can avoid the significant backflow of the blood during the procedure. Now we're doing the dilatation of the axis up to 26 French. Usually this is without any problems. And with each taking out of the dilators or then changing, I pull on the sutures so that we have no blood. You see here the nice system, the tip of the catheter, the pre-mounted system, so it comes already, everything is prepared. It's a dried bovine pericardial valve. And then here you see how easy the system can be introduced. And maybe I'm going to stop here also for a second. You see now here the system. This is the nose cone. Here is the valve system in this pre-mounted sheath. You can appreciate more or less these two indentations. In between is this belly of the valve. And this belly, as I said before, we want to place so that we have some blood flow from the left side over the anonymous vein into the superior caval vein, so that we're not obstructing this with our system. So we want to place this rather high, but not too high, so that we are avoiding this, avoiding any obstruction. The pulmonary catheter serves, as I said, as the other landmark, so that we want to be above this pulmonary artery catheter, so that the valve is not dropping below the pulmonary artery catheter. So this serves us and gives us a little bit more additional stability of the valve. Then the procedure is rather simple, as you will see. Just by pulling this wheel here, we're going to unsheath the stent. This is being performed in several steps. You see now in a few seconds it starts just flaring, and I'm trying to orientate myself here by the ribs and the subclavia, so that this upper stent part is more or less located in here. Now you see that the belly has already been expanded. You always have to take a little bit of time until the stent is getting accustomed to the temperature. Then it's expanding even further. So you can't do this in just 30 seconds, but probably the entire procedure to expand this valve is always stopped for a couple of minutes after each of those steps, and it takes about 10 minutes to release the entire stent. It's been anchored with three anchors in the delivery system, and then you're going to place this very carefully, one anchor after the other is being released. Here's one anchor is in, but the other two are still out, and the other two are still in the system. Now the other anchors came out at this point. Again, we have to wait a little bit, like a minute or so, and then we can slowly retract this catheter system. We don't want to put some tensioning on the stent, of course, so that it is not dropping into the right atrium. And then after taking this out, then we remove the pulmonary catheter and insert it now a pigtail catheter into the hepatic vein, so that we can also see the blood flow from the hepatic vein into the inferior caval vein. Now this is the exchange now for the inferior stents, valve stent system. And as you have seen perhaps now, with this pulling tight of the set suture, there's almost no backflow, although we have a pretty significant hole of 28 French or 27 French in the groin. Now this stent, I'm going to stop this also here again so that you can appreciate the fluoroscopic appearance, is again mounted in this delivery system, pre-mounted as the upper one. It has a first part up here. This is the covered part, again roughly around 22 millimeters, and this is the lower part which is uncovered, and the valve is in this upper part. During the placement, and also here we're doing, and I'm just replaying the angio of this, of the flow of the blood from the hepatic vein, so that we can appreciate, probably here is the transition from the hepatic vein into the right atrium. We're discussing about the height, what is probably the best. Well, usually there's a little bit of oblique transition from the diaphragm, so we need to be sure that we are high enough on one side, but also not too high for the other side. And we can still retract the system, also the upper one, during the release, but we cannot insert the valve. So starting higher is easier and pulling back, but not the other way around. Now you see the system is flaring again in this position. We are orientating ourselves here also with the spine. And then by transthoracic echocardiography, we can appreciate now here the inflow part of this inferior caval vein into the right atrium. This is the stent, this is the wire. We can measure this distance. Usually we want to have like a height of around 15 to 17 millimeters so that we get a good sealing. Right now it's just the upper part is opened, not the lower part. So there is still some backflow as sometimes in here, but as soon as we further expand the stent, as you will see, we're trying to see that we're really generating here a good sealing. Now the valve is already a little bit further expanded. We're checking again before we fully release that we are not obstructing the hepatic veins. Then you can also pull out the pigtail when you're certain that you have the correct height, and then the three anchors again are being released. Here's again a control by echocardiography. Now we have already a significant portion of the stent expanded. Here's almost no backflow into the hepatic veins. So there we have a good pressure separation of the right atrium to the caval vein. And now you see that the stents are being, or the anchors are being released. Again, this is the entire procedure for one stent, also for the low one, is somewhere around 10 minutes with some in-between breaks. There's now all the anchors are being released. And then we can also pull back the catheter, the delivery catheter system, which you see right now. I'm going to jump a little bit further. Now, how can we assess our procedure? Of course, we can see by echocardiography if we have some backflow into the hepatic vein. Here I'm performing a right atrial injection to see if there's some contrast is coming back into the upper or lower caval vein. It's not displaying here well, but we had a very good sealing. And what you can also appreciate is the hemodynamic response. With this placement, you get a significant further ventricularization of the right atrial pressure. Now the right atrial pressure in systole is around 70 millimeters of mercury. But in a second you will see that I'm pulling back the catheter to the below the caval vein, below the stent into the inferior caval vein, and you see the significant pressure drop. So they have a good separation of the right atrium to the lower body half. With this, we're almost done in this procedure. We're closing the groin with the ProGlide, which was already delivered. Here's an echocardiographic result, which matches very well the hemodynamic response. There's almost no backflow. A little bit is coming through the valve in here, but this is insignificant. And I jump a little bit further. This is it's very simple. The patient is going back to the ICU ward. What some of the patients are experiencing is some significant shoulder pain in the first hours and days after the procedure, because the phrenic nerve is somewhat a little bit stressed by the stent. This is something what we need to tell our patients up front, but usually after the second or third day, this also goes away and the patient is significantly improving. Thank you very much.